and share screen. Share this one. Share. All right, guys. Good evening, everyone. This is our third session, I think, on the cerebrovascular disease, and we'll try to cover some questions. Maybe start with Dahman. Hamad, you want to start, Hamad?
Yeah, sure, Doctor.
Okay, go ahead. Bismillah.
A 51-year-old man presents with severe left arm fatigue while using his arm and pre-syncope when raising his arm above his head. He has unequal upper extremity blood pressure and non-palpable left radial pulse. CTA showed an artificial left artificial left subclavian artery occlusion. Carotid subclavian bypass is associated with. So he has a Steele syndrome, and they are suggesting carotid subclavian bypass. So we'll see what is.
So the question now. So it's exactly what. So we have Steele syndrome from the symptoms, not the TIAs. And they want us to know what is the best option, you know. Carotid subclavian bypass. Okay, this is what we do. Already do stenting, but now let's talk about carotid subclavian bypass. Most people now they do already stenting for carotid occlusion. I mean for subclavian artery occlusion, but also you can do a bypass. All right. So what's the problems of bypass? Let's see what's the option. When you do a bypass, we have two kinds of surgery, right? We have carotid subclavian bypass or transposition. Correct?
Okay. Yes.
Do you are familiar with these two cases? I mean, two type of procedure? Or have you seen one of them, or you see just one, or you saw both of them? Hamad, did you see? I think bypass, I'm sure you saw, but did you see any transposition?
No, transposition never.
Transposition is more difficult. It's better because it's not better, but it's patency is the same really, but it's just you don't have a graft, you know, so primary anastomosis. The only two problem was this: you need to dissect really down, you know, to get to the very close to the origin of subclavian, you know, so you have enough stump so you can rotate it, and then when you do, you rotate it. We don't cut and just put it, so you rotate it, and to rotate it, what you need to do. Two things fix the subclavian artery. We have the lemma, the internal mammary, left.
Yes.
We have the vertebra. Okay. Lemma is the lower part. So to rotate, you need to ligate the lemma, the internal mammary. So you can rotate the artery. Of course, you keep the vertebra. You cannot ligate it. And then you can rotate it and bring it up and do carotid subclavian transposition or bypass. So this is the problem, is that you're going to sacrifice the lemma. And now lemma is very important. A lot of people like to use it, especially cardiac for you know, for heart surgery. So this is the downside of the procedure. The second thing is that we are working the left side. What we have is the left side, an important organ can cause a leak in that area.
Thoracic duct, I think.
Thoracic duct, right.
Yeah.
So you can injure it, right? Because if you go deep in this area, there's a good chance if you injure it, you end with a really very bad headache, you know, lymphatic drainage.
Yes.
And most of it is drainage go to the chest and patient end with a chylothorax. And I have one case like that happen to me. It is very difficult to manage it, you know. So this is a two side, you know. What you gaining from this procedure? Again, the only thing you gain from that is that you don't put a graft, that's all. But if you look at the patency, all the study shows no different patency, you know. So that is why most people really, you know, stay away from the transposition. Now most people do carotid subclavian bypass, you know. But so we can go, let's go through that. Yeah. Let's go through the question.
Yeah. So carotid subclavian bypass is associated with lower stroke rate than subclavian carotid transposition. Okay, lower. Yeah.
So it's correct or no? No, let's start one by one. Is a stroke rate or not?
There is no, I think, no difference between the transposition and the bypass in that, in that area.
Correct. It's not different in
And,
stroke, death, and even patency. So these three things
Yeah.
is what as I'm saying. It's no different between the two cases at all. So you can go to the
Okay.
next one.
Lower death rate than subclavian carotid transposition. This is also a no.
Okay.
And C, higher combined stroke and death rate than subclavian carotid transposition. Also, this one has no difference. So higher rate of Herner syndrome compared to subclavian carotid transposition. This may be
No,
correct.
just a
maybe.
second.
Ah,
Just say no. Horner syndrome happened from injury to what? You know what chain?
T1,
chain.
yeah.
Okay, sympathetic chain, right?
T1. Yeah.
Which
yeah.
one you need to dissect more there down? At the transposition or sub bypass? Which one need more dissection? Deep.
The position, the interposition.
Transposition, right?
Yeah.
So really transposition has a higher rate than calcium, not the
No.
opposite, you know?
Okay. Yeah.
Because he's I say calcium has a higher rate of Horner syndrome compared to
Yeah.
subclavian, you know? So it's not,
Yeah.
you know? So this is wrong.
So improve patency when performed with synthetic graft compared to autologous vein.
When the one you did the subclavian, you saw them, was a vein or we use synthetic?
It's synthetic.
Synthetic. Okay. Did you see anyone done with a vein?
No.
Not
no. Yeah.
Yes. So really, so the reason why, because usually the patency is better with, it's the only place patency better than bypass than the vein. You know why?
I think because of the ring and the movement with the clavicle.
The kink.
Yeah.
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 So it's a kink. If you put a vein, it's very easy to be kink, especially with the neck movement, you know, and if you don't put it right, you know. Whereas the reason why I use the one with the ring, you know, to give more more strength. The reason why they found the patency is better than when you use BTFE than use autogenous vein graft. And the reason why we use always synthetic, we don't even think about autogenous, unless if you have a condition, infection, whatever, it'd be an extreme. But our first line always is a synthetic graft. Okay.
Okay, clear.
So any questions? So it's clear, this one. So again, it's no different in patency, stroke, death, no different, you know. The only different, the only thing, if you want to do it and get a good result, you have to use synthetic graft, okay?
Yeah.
All right, let's see who's next. The Sam, you want to take next question?
Yes, sir.
22. Let's see what they said. Okay, go ahead.
A bypass between the subclavian and common carotid arteries is the most commonly performed extrathoracic bypass for symptomatic obstruction of the brachiocephalic arteries. In cases where subclavian carotid transposition is not feasible, the ideal conduit for bypass is.
So what we use, we think, what usually we use when we do surgery?
The bypass usually will use the artificial one, PTFE.
Yeah. With a ring, right? Yeah.
Yeah, with ring.
You do. So that's it. I mean, yeah, the reason why, because they found is that the best result is when you use a PTFE, you know. So let's go through the question, what they said.
Yeah, greater saphenous vein. I think it's small.
Not small, as we said before. See, the same like this is a question because the kink, it's kink. We don't use a vein. Okay.
Yeah.
The only time we use a vein, you know when? If you have to go really high, like you do aneurysm, sometimes like it's not common, but you can see common internal carotid artery stenosis and subclavian artery occlusion. So you want to do them both. So you do endarterectomy of the left common carotid artery and carotid subclavian bypass. And the way you do it is that instead of putting a patch, you put a vein as a patch. And then you do it all the way down to that. That's the only time you can use a vein because they're long, you know. And then you need to patch the common internal carotid artery. So the only time we use a vein, of course, if you have an infection or if you're going to do internal carotid artery endarterectomy with the carotid sulci vein bypass. But other normal condition, always use synthetic and always use PTFE with the ring.
Yeah.
So saphenous vein is not a good option. Okay.
PTFE or large diameter cryopreserved vein. It
Okay.
sometimes will be thrombogenic or يعني
Yes,
not helpful.
cryopreserved vein is very bad. I mean, we don't even use them in the for FEMPA bypass or something like that. You know, it is should be your always last choice. Cryopreserved vein, they thrombosed. Patency rate is not more than 1 year, so they are not good for anything, for any kind of bypass. You know, hypogastric artery.
Hypogastric artery.
We don't
It's
use
also
it.
small, yeah. Autogenous femoral vein.
No.
Yeah.
Well, we don't do it, right? Just think what we do really. I mean, why you should go to the hypogastric artery? So imagine you open the abdomen to get hypogastric artery, or get to the femoral vein and get the patient get to the leg swelling. There's no reason, you know. So all doesn't make sense. All this one. So the only thing that makes sense is BTFE.
Okay.
All right.
Okay.
All right. So let's say who's here also. Amjad, you are intervention or you are still vascular?
No, still vascular for sure.
Vascular. So you want to take a question? Oh, this
Yes,
is a big
sure.
one. All right. What's that?
Intervention right now.
That's good for intervention. Let's see what's that. 62
Okay.
years old.
A 60 years old man present emergency room with the new onset express aphasia and right arm weakness that resolved. He has no incomplete occlusion of the left internal carotid artery. Identify and occluded left, the CT scan identify and occluded left internal carotid artery and a patent but narrow external carotid artery. The contralateral internal carotid artery stent is widely patent. He has a dominant and patent left vertebral artery and diminutive right vertebral artery with approximately 30% stenosis. He started on antithrombotic therapy with heparin, but has a recurrent episode of arm weakness. The next appropriate management is.
Okay, before we go, let's see what he has. Okay. He has an occlusion of the left ICA, correct?
Yeah. Yes.
Complete occlusion. Complete occlusion,
yes.
Correct?
Yeah.
But he's coming still with a TIA on the right arm. Okay?
Yeah. Yes.
They look at the other internal, it looks fine. They have a stent and it's wide patent, right?
Yeah.
Then they look at the vertebra. They found the left vertebra is patent, the right vertebra has 30% stenosis. Okay.
Yeah.
They start him on heparin, then put him on, let me see. They start him on heparin. Okay. So now we're going to do, he's still keep getting symptoms, even though the internal carotid artery is still. Let me ask a question. If the internal
Stump
carotid artery
syndrome.
is occlusion, correct? Let me show a picture, sorry. We didn't see the picture here. This is the internal, and this is the external, okay? And this is an occlusion.
Yeah.
But in general, if the patient got internal carotid artery occlusion and he has no symptoms, does that mean he's already safe, or he can still get stroke from that?
He can get as like Stump Syndrome.
Yes. Yes, he can get about 5%. So always I tell the patient, even though he got lucky, he didn't get stroke from occlusion, but he still have a chance. That's why I still have to put in antiplatelets, you know? So he has what they call carotid stump syndrome, okay? But how do you explain that? Let's explain to the people how this happens. I mean, it's internal occluded. So how is he still getting TIAs? Because this guy is still getting TIAs because he has a right arm weakness, right?
Yeah.
Is what he's coming. So that means he's getting TIAs. So how do you get TIAs and internal still occluded?
Either through
This is what the carotid stump syndrome.
Through the external carotid artery.
But when we do a surgery, we don't pay attention to the external. Sometimes severe 90% stenosis, we don't stent it. We don't do anything for the external, right? Like many times we end with 90%. If the external is going to give us a TIAs, then why we don't fix external when we do carotid surgery, or why we don't consider external is a risk factor for TIAs?
I'm sure, I don't remember how, but I think one branch of the external is still communicating intracranial, ophthalmic, but I'm not sure.
No, that's correct. But I'm saying is that if this is what happens, why we don't fix it when we have the carotid stenosis? Like when you have an external carotid stenosis, it's yes. I mean, ophthalmic is communicated with the middle cerebral artery. This is correct.
Yeah.
But the question is that why we don't get the TIAs? Why we don't pay attention to the internal, external? Why we pay attention now? It's very, very simple. Go ahead.
Yeah. Because this will be the only source, but when other cases, when I have a patent internal carotid, there will not be another source for embolization through external.
Well, if you have a 90%, you can get the embolization for 90% as external. If you have like 90% stenosis, it's going to give you turbulence like an internal. But always we say we don't worry about it because the clot will go to the skin, so we don't worry about it, right?
Okay.
But now it went to the brain. Why doesn't go to the brain there? You know? You see? This is I'm trying to figure it out. Why was it different? Why now it's become an important when another situation is not an important?
I'm not sure, honestly.
Yeah, it's a bit tough. I mean, the reason why you see when the antenna is open, right, then the flow is antegrade, you know? So that means there's a communication between the internal and external, you know, but nothing can go from external to the internal because the flow in the antenna is antegrade, you see? When the antenna is occluded, then the flow is going to go from the external to the internal. So the flow become retrograde the internal. Then any clot in the external can go to the internal because internal is occluded, so pressure is low. Always the pressure go from high pressure to lower pressure, right?
Yeah.
So the external, the pressure is high, and the internal now pressure, I mean, see distal internal I'm talking about, intracranial, especially if you don't have circle of Willis. If you have a circle of Willis, this will not happen, you know, because circle of Willis will keep the pressure high in the internal and the same as external, so the blood will not go from external to the internal, you see? But if you have an internal is occluded and circle of Willis is not complete, then one of the collateral for the internal is get from the external. Then the blood start flowing from the external to the internal, you know, through this collateral, especially as through ophthalmic artery, as you said, you know. Then any small clot can go through the external, through the branches, especially ophthalmic artery, and go to the brain and cause the TIAs. Did you get it?
So it's like
You
the
understand
resistance would, what I understand is that the pressure will be higher in external carotid when we have occlusion, complete occlusion of internal carotid.
Not to be the higher, the internal will be low, because when the internal and external is open, then the flow will be equal. So everyone go to its place. There's no cross between the internal and external because both the same pressure, correct?
Yeah.
Nothing will go from higher to lower, lower to higher because both same pressure. But when the internal is complete occluded, then the distal antenna is low pressure, correct?
Yes.
And the external is high pressure. So the blood through is going to go from the external to the internal as a collaterals, you know? So then any small clot in the external come from the stump or from the external itself, then can go to the brain and cause a stroke.
Okay, clear.
I don't know if you understand. So that's the reason why when complete occluded, yes, you can, but if you have like stenosis or the internal is open, then external is not important because any clot in the external go to the skin. It cannot push the blood flow through the internal because the internal is the same pressure as external. So it will not go to the internal. But when the pressure go down, then yes, can go from external to the internal, you see? Then you get what we call the carotid stump syndrome, you know? Then in this situation, we just go, we ligate it, and you can fix it. And if there's any problem is external, you fix it because now external is the source of your TIAs, you know? Now is that external is as an important. Because you're getting TIAs, that means you have good collaterals, that means external is important now because it give you collateral to the brain. Because if there's no collateral to the brain, then he doesn't get TIAs. So two things now, tell you now you have external is important because it's giving blood supply to the brain through the collaterals, and tell you if there's any problem and getting, so it's not enough just to ligate the stump. If any stenosis is external, you have to fix it also. All right?
Yeah, clear. Thank you.
The other option, you can ligate it, but I don't like that, because if you ligate it, and this is source of blood flow to the brain, you're cutting blood flow, you may get a stroke. So I will not ligate it as an option, you know.
Mm-hmm.
All right, let's go through the question now. The answer, I mean, yeah, the
Okay.
question, go ahead, yeah.
So A, continuation of heparin with bridging therapy to oral anti-thrombotic agent. I
We
don't
don't
think
need that,
so. Yeah,
because we don't give
already patient.
antithrombotic, we give
Yeah, antiplatelet usually.
antiplatelets, yes. Usually we don't give, anyway, when you have TIAs, always give antiplatelet. We don't give antithrombotics, so it's
Mhm.
not the right answer, okay?
Okay. B, placement of endovascular stent in the right vertebral artery. I don't think that the pathology related to vertebral artery.
Correct.
Ligation of left internal carotid stump and external carotid patch angioplasty. This is sound correct.
Correct.
Right vertebral artery bypass, no. External
Correct.
carotid to internal carotid artery bypass, no. So it
No.
will be C.
This extra carotid to internal carotid, nobody do it anymore. So anytime
Yeah.
you see any question, by default it's wrong, you know. As you
Mhm.
said, vertebral artery will not help, because it's not a vertebral artery center, it's not a posterior, it's anterior circulation, you know. So
Mhm.
I think, you know, I mean, I never had to do something like that, but I know patient can get stroke after occlusion. That's why I put on antiplatelets, even with complete occlusion. But I never saw patient with a stump. I read about it, but I never saw patient with a carotid stump syndrome. But this is what it is, okay?
Mhm. Excellent.
All right, it's good. Let's go to the next question, 24. We go back to Muhammad. Dr. Dahman, is still there?
Yes, Doctor. A 57-year-old active man is referred for management of an asymptomatic 3.6 centimeter fusiform left internal carotid artery aneurysm. He's chronic smoker and has no history of neck trauma. CT angiography demonstrates a significant volume of intramural thrombus in the aneurysm sac with approximately a 60% stenosis of the internal carotid artery flow channel. So he has no history of MRCS fogax or other transient ischemic attack or stroke symptoms. The indication for surgical repair in this case is.
Okay, before you start,
So
they're talking about asymptomatic internal carotid artery aneurysm, 3.6, correct?
Yes.
This is what the whole scenario about is, plus 60% stenosis of the internal carotid artery. Okay.
Yeah.
So do you know what the indication, or do you remember what the indication to repair carotid internal carotid artery aneurysm? Do we have a, I mean, first, do they rupture or they emboli? Which one's more?
You are afraid from emboli أكثر من rupture. Yeah.
Correct. Like the other artery, right?
Yes.
So they were afraid of emboli. So what size we recommend to go and treat them? Do they have a special size?
I cannot recall the exact number, but maybe 3.5 is the cut. I'm not sure.
I mean, 3.6 for sure is big. So make it easy for you. You know, you don't even remember the number, but 3.6 looks big.
Yes.
So they make it easier for you. If they give you like 2.5, it becomes maybe a bit more difficult and confusing.
Yeah.
But whoever put this question, he's a nice person, you know, put 3.6. So need to be fixed, no question, you know. For the sizing, really, it's a controversial. I don't think we have a cut down. People, they go with a double size of the internal. This is what usually they do. Because you see internal different from person to person. So if you reach the double size of the internal, they recommend to do a surgery. Or 1.5 from the common carotid artery. What this was a paper said, you know. So more than 1.5 of the common or double size of the internal. So they didn't try it. Nobody agree on certain size like 2.6 or 2.5 or 2, you know. So always remember that. But again, even if you don't remember, this is 3.6 is a big one. All right, let's see what the question are.
So the indication of the surgery: A, risk of rupture of carotid artery aneurysm more than 3 centimeters in diameter. Okay. So
Now
B,
let's
lack of
stop in this
efficacy.
one. Now let's stop on this one. What you said before, that rupture is not a concern, right? So they
Yes.
already ruptured, they merely the emboli. So reason why this is not correct, not because of the size, because sometimes they get even 4 or 5, they don't rupture, but they get the TIAs and stroke. So risk of rupture is not our concern. Again, as I said, TIAs. That's why this question is wrong. Okay, let's answer.
Yes.
Okay, let's say to next one.
B, lack of efficacy of anticoagulation therapy in preventing ipsilateral stroke. So this is
wrong
this,
because
yeah.
Go ahead.
Yeah. C, risk of Horner syndrome with large internal carotid aneurysm.
Horner
Horner
syndrome
syndrome
is a bit far.
sympathetic. Yeah, this is
Let's keep
far.
going. Let's see.
Maybe
Okay.
vagus nerve more affected than.
No, but I'm saying, what's the indication for
sympathetic.
surgery? They're not going to
Yes,
tell
yes.
you. They're not asking what can happen. This is an indication. Is this
Yeah.
indication because to remove Horner, to prevent Horner syndrome? No,
No.
we don't do surgery for this reason.
Yeah.
We
Risk
don't
of
because of
hemi-
rupture. You see, this is a question. You have to understand what's the question. We don't do
Yes.
surgery because of the rupture and not because of the Horner. Okay.
Okay.
Let's say next one.
Risk of hemispheric stroke due to intramural thrombus. So, and
Why we do a
E,
surgery? Indication for surgery because of the
to
risk
rule
of
out.
hemispheric stroke due to intramural thrombus. Correct or wrong?
Yeah, you have
Yeah.
intramural thrombus, yes, and you have aneurysm, so the risk of stroke is high. You have
Yeah.
to prevent
So
it
that is why
by
we do a
doing this.
surgery. So this is our indication
Yeah,
for surgery
this is the
because the risk
indication. Yeah,
of hemispheric stroke is
due
high
to that.
due to intramural thrombus or because of the size of the aneurysm, you know. But the reason why we do, so we do it only because to prevent stroke, not because of the rupture, not because of the Horner syndrome, not because it's not going to work, but we know that patient with aneurysm high risk of stroke. Okay. Okay. Last
Presence
one.
of E, presence of internal carotid stenosis of 60% meets requirements for repair. No, I don't think this is
not the indication. Indication is aneurysm.
Yeah.
Correct. Okay.
Yes, sure.
So it's a bit tricky, but it is
Yeah.
straightforward, you know. So the reason why, again, so always do the aneurysm to prevent stroke, not rupture. And again, the size is not, unfortunately, we don't have a definite size. We go with a double size of the ICA, okay?
Right. If we can treat this patient, doctor, how we approach him for treatment, definitive treatment?
Depending on the age, how age is guy? Let me see, 57, you consider as young,
Yeah.
you know?
Yeah.
Always I prefer resection and put interposition vein graft. This way we do.
Okay.
Yeah, this is the best way. Some people, they put a cover stent, but I don't like it. Cover stent, they don't work very well in the internal because they are thick and the internal is small. So they don't, but sometimes if you have like, you know, for some reason, like, you know, I mean, bad neck has a radiation, you had, you know, high risk for surgery for some reason, then you can do a cover stent. But first option is really resection and interposition vein graft, you know.
You will resect it, we resect it all, then we do end-to-end interposition graft. Okay.
Correct. Or you can keep the posterior wall. I mean, same like we do the aneurysm.
Yes, and you
can
cover
do
it
that,
after that.
and put a tube graft in the middle and use to cover it. Yeah, you can do that like aneurysm, or you can cut completely, depending on what's easier for you.
Okay.
Of course, when you cut, always cut in a beveled way, because you don't want, when you cut any artery you want to do, don't cut them like 90 degree, because you get the stenosis. So you got the artery always beveled, and the vein will be beveled. So you have larger way of the larger area of anastomosis. So even if you get stenosis, you have a large area. So you don't get transfers, you get always beveled, you know, in both. And this is what we do. And anytime we do end to end, always we cut the end in a beveled fashion. Okay.
And the exposure, like carotid endarterectomy.
It's exposure, yeah. It's a bit more difficult because the aneurysm there, you know, it's a bit more difficult than regular because you see aneurysm in your face. The nerve will be pushed, maybe displaced. So you have to be careful with the nerve, especially hypoglossal nerve, vagus nerve, you know. And then you have to go higher as they to get to the aneurysm. So it's technically is more difficult than endarterectomy. But it's not impossible, you know. It's not like very, very difficult, but it's a bit challenging. It's more difficult than carotid endarterectomy, it's no question, yeah. All right. And then especially if you want to shunt, it's become already challenging if you shunt. The reason why I said if you open the aneurysm and leave it there, if you shunt, at least the antenna will not go up, will not like retracting up. Then you have to look for it and you have no control. But if you open the aneurysm and leave it in the back, it will hold the both end, the aneurysm sac itself, until you finish your anastomosis, or if you put, if you want to put a shunt, you know.
Okay.
So yes, and again, if you want to do a shunt, it'll be a bit more challenging, but you can do that, you know. You just put the vein through the shunt, and you do end-to-end anastomosis, and then you do end-to-end anastomosis, and before you finish, you cut the shunt and you remove it, you know. Is the way how you do
Okay.
it, with the end-to-end anastomosis with the shunt. All right. All right, let's go to 25. Sam, you still there?
You are, yes.
All right, let's get this one.
A 75 years old man underwent right carotid endarterectomy 8 years ago using a polyester patch. Over the past 2 months, he has noted intermittent redness and swelling of the right neck. On examination, there is moderate induration and erythema of the right neck and a small draining sinus. The management options most likely to prevent persistent or recurrent infection is
So what we have
Okay.
here, Sam?
yeah artificial or يعني polyester patch.
Yeah,
Yeah,
and it's
so it's a
infected.
foreign body. So
Yeah.
we spoke about it in the previous question. So I think
Okay.
we need to resect or يعني to put a venous patch. This is the
Yeah. Why need to
yeah
resect the artery? No, just take it out and put a vein graft, right? Why need to
yeah
resect the
yeah
artery, the whole artery? Usually
resect
we just
yeah
take it
the
out,
patch
unless
only.
unless if you go there and find the wall, of course you cannot take a sutures. Yes, I
Mhm.
mean you have to be prepared for both way. But if I
Yeah
go there, I usually take the patch first. I see the edge. If the edge is very fragile and they
yeah
cannot hold sutures, then yes, I resect it, put interposition vein graft.
mhm,
But otherwise, if you take it and the artery looks fine, I just put a vein patch, as you said, you know.
yeah.
Okay.
So a
Let's see what they
excision
said.
of infected patch and replacement with PTFE. No, it's also a foreign body.
Yeah.
Treatment with broad spectrum intravenous antibiotics. I think because of recurrent infection and there is already sinus, so antibiotics is not an option, except if there is high risk for surgical intervention.
No, but the question said they want option most likely to prevent persistent or recurrent infection. Antibiotic will not do that. It may cool it down now, but will come back,
Yeah.
right? So will not
Yeah.
prevent persistent or recurrent infection. So antibiotic, yes, we're going to give it. It may buy more time, but you know that the moment you're going to stop it, you're going to come back because the foreign body has to come out. So it's not good for persistent or recurrent infection. Okay, next one.
Prompt irrigation and drainage. Yeah, we have to remove the source.
So there's
So
not enough.
drainage alone is not, yes.
Mhm.
Excision of infected patch and replacement with autologous tissue, yes.
Mhm.
Excision, debridement, and carotid artery ligation. Yeah, there is no indication for ligation except if there
Yeah.
is bleeding or something to control.
Yeah,
Yeah,
unless if
so
yeah, but you don't do
mhm,
that unless if you do like an occlusion before you know ahead of time, it will not
mhm,
affect the patient for some reason, you know. But ligation you may do the stroke unless you have good collateral, unless you have you know that he has a good collateral and all the things. But this
yeah,
is an extreme, you know. As I said, maybe if he came back second or third time, all the things. But
yeah,
the normal treatments to take it out and replace the autogenous vena graft.
Yes. Okay.
All right, straightforward. It's a nice question. Today, the question is better than the trials, huh? The question is more interesting today.
Yeah, definitely.
Yeah, let's come to Amjad.
Yes, hi, doctor.
Here we are with you again.
A 40 years old woman is referred for duplex ultrasound of the carotid artery for an asymptomatic carotid bruit. She denies neurological symptom or vision change. She has no hypertension. The duplex demonstrate finding consistent with FMD in the internal carotid artery. She is started an aspirin. The most appropriate next step in management of this patient is I
Okay,
think I need
before
to
we start.
survey another. I need to
Yeah.
see renal artery.
Okay, before we do that, let's see what we have first. What the
This
patient
is-
has.
This is a 40 years old lady referred for a duplex finding.
So she has
carot-
FMD, right?
Yes, yeah.
And she's asymptomatic. This is
She's
very good question.
asymptomatic and aspirin.
Okay, so how we treat asymptomatic FMD? If you do a CT angiogram and you find patient has a fibromuscular dysplasia, what the guideline? Do we treat them? Do we go with the symptoms, degree of stenosis? How we treat them?
Uh,
If asymptomatic, let's say first asymptomatic.
If it's asymptomatic, patient need just to be in medical therapy in form of antiplatelet, just to
Okay.
prevent TIA or stroke.
Mhm. And if patient came with symptoms, how
If
treat
symptom,
FMD?
either we have two options. Either open, it's an option, and endovascular also another option.
Okay, that's correct. But most people, they like to do endovascular because they respond very well to just ballooning, you know.
Mm.
I don't have even to put a stent, you know. But yes, you can do even an open, you know. But usually they respond very well just to the dilatation, balloon dilatations, you know.
Mhm.
Before they used to open and do dilatation with the dilators, you know. But now we have technology, we can do endovascular, you know.
Mhm.
Because sometimes the artery is too high, you cannot reach it with like, you know.
Mm.
So it's not good for patch. If you just go put a patch, it's not going to work because this is multiple area of muscular fibromuscular dysplasia. This one very well dilatation, either with a dilator or with a balloon. But now they do with a balloon. So this is simple. Symptomatic, we do ballonoplasty. Asymptomatic, just antiplatelets. We
Mhm.
don't go with a criteria. We do it for like 90% stenosis. You know, what we talk about carotid endarterectomy or carotid disease. This is different. You know, it's different pathology. This is just we don't agree with stenosis, symptomatic or asymptomatic. Symptomatic, dilatation, asymptomatic, just antiplatelets. Okay. We don't go with the numbers 50, 60, 90%, whatever numbers. Okay.
Mhm.
Because different pathology. All right, let's see what's the option. The first one.
Anticoagulation. No, usually we give antiplatelet, as we said.
Correct.
Carotid duplex ultrasound. Already the patient, she have an Doppler, not a duplex. So she might need it.
Okay.
Percutaneous balloon angioplasty of internal carotid artery. We said she's asymptomatic, so no need for intervention.
Correct.
Carotid angiogram. I don't think I will go for, as a next step, I will not go for carotid angiogram. MRI
Right.
of brain, also it's not the first step to be done. So it's B, carotid
Okay.
duplex ultrasound.
This is yes. I mean, yes and no. Yes, we do carotid ultrasound, but he already has a carotid. The duplex ultrasound is like, you know, he already had duplex demonstrate.
Mm.
I don't know why give us this option really. I didn't understand really why they could carotid ultrasound. Because he has duplex demonstrate finding consistent fibromyalgia. Yeah, I mean,
Yeah.
artery. So he already has a duplex. Maybe he meant like follow up with a duplex ultrasound every 6 months. It could be, but it's just, I mean, it's not wrong, but it just doesn't round right. It doesn't make sense to me why he put it, you know. It really is the answer is a bit tricky. Is the MRI of the brain, and you know why is that? You mentioned that before. I thought you were going to answer because you said the answer before. You said next step I'm going to look at the renal artery, correct?
Yeah.
because they are usually the most common place for FMD is the renal artery, and the second place
Yes.
is the internal carotid.
Yeah.
You're right. Yeah.
Yes.
So you're right. So your thinking process is correct. You were looking for something else, but you forgot that FMD also associated with intracranial aneurysms. It's about 13%.
Yeah.
So really, when I tell you FMD, because this is more serious than renal. Yes, I'm sure you're going to look for renal, but if you go with this question, you have, because intracranial aneurysm could be a deadly, especially how old she's 40. These are the reason why young people suddenly they die. They have small aneurysms, they ruptures. So intracranial aneurysms, asymptomatic is very risky. You have to treat all intracranial aneurysms. So when you have an FMD, it's just a trigger for you. Oh, let's go. Maybe he has intracranial. We can prevent a death on this patient. Again, the incidence is really not low. It's about 13%. So it's really high. To find intracranial aneurysm. So anytime you find the carotid FMD, I think next step to get a brain MRI, as I said here. So it's a bit tricky question, but I think it's a good teaching point to keep it in your mind when you see patient in the clinic with, especially young people with FMD. Okay. Very good. All right, let's see where we are now. 26. Oh, so 26, 27. Let's go to the Hamad.
معك دكتور. 67 years old man, yes, has a large left-sided skull-based tumor involving the entire carotid sheath. Reconstruction of carotid artery is proposed, but may not be technically feasible due to the location of the tumor.
Okay.
The preoperative testing results that predict favorable outcome with simple ligation of the carotid artery is. So what
they are talking, before you go there, they are talking about you decide to ligate the carotid artery.
Yes.
This is the plan, because there's a tumor involving the internal carotid artery and you're planning in the surgery, 90% you're going to ligate the internal carotid artery. So before you ligate, what you need to do? What tests we do usually?
Occlusion test.
Balloon occlusion test,
Yes, balloon occlusion test.
Occlusion test. So this is a whole question about balloon occlusion test. Do you know how long they leave it there? The balloon?
I think 15 minutes.
Yes.
I don't know.
No, usually they go really higher, longer to be sure there's good flow. Usually go to the 30 minutes,
Okay.
So usually they do it for 30 minutes, There is a test which I don't know if they do it here. We used to do in a state called SPECT. SPECT, it is when you do the occlusion test, you give a patient to inhale as a gas called xenon, inhale it, and you do a CT to the brain. So you do, and then you see how much exon is tell you how much it goes through the brain and tell you how much blood flow to the brain. So when you occlude it, you compare the right and left side of the brain, which it looks like red, blue, and red, all these colors, and they can tell you how much blood perfusion to each part of the brain. So it's supposed to be equal, or they may go a little bit on the affected side where you inflate the balloon, but should not go more than 0.9. If go more than 0.9, that means this occlusion is a serious, Usually when we do that, if his patient is unawake for some reason, he's intubated or for some reason, they cannot. But usually just inflate the balloon and see if he's respond, if he get any symptom, this is much easier, But again, if for some reason patient is, intubated and because a tumor and you can assess it and you go to occlusion balloon, then how you can assess if he's getting enough circulation, then you go with the SPECT test, okay? This is the idea behind that, all right? So you have to know it, Again, I don't know if we have it in Saudi here, but we did it before for patient who's intubated. So let's go through the question. I think it's a good question because as a practical question, you may need it in your even, clinical life. So let's go through this question and go one by one. So what he's saying, the predictor favorable outcome. Which one say you have a good outcome? That means he will tolerate that. This is what the question. What of these tell you that the balloon occlusion test is negative or favorable outcome? Okay, that means he will tolerate the ligation of carotid artery. So let's go one by one. First one,
A, a minor reversible aphasia after 15 minutes of balloon occlusion of the carotid, occlusion of the carotid artery. We said 30 minutes maybe.
Yes, yes,
Oh.
because if we get reversible aphasia, but after 15, no, because they said you have to go for 30 minutes. So 15 minutes is not enough.
Oh.
I don't know why I didn't put this number. Somebody put the numbers, and this was the number you have to remember, 30 minutes.
Okay.
Of course, what you need to heparinize the patient. Don't go and include the internal carotid for 30 minutes. You get thrombosis. Don't forget to heparinize the patient very well. Okay.
Okay.
And be sure his patient is awake. Usually what symptoms they get, symptoms, he doesn't have to get like really a stroke. They get like restless, you know, they
Yeah.
get agitated.
And-
Sometimes they get some weakness, aphasia, sometimes they sit here. So you don't expect like a lot of symptoms, but anything you see
And
changes,
these are-
this is a sign, yes.
Yes.
All right, next one.
So B, the ratio of xenon enhanced single photon emission computed tomography activity in the affected side compared to the control side is 0.7 to 0.9.
So what does it mean? When you see 0.7 or less than 0.9, that means the flow in that side is affected with the balloon, right?
Yeah.
So this is a bad sign. He's looking for favorable sign, the good sign. So this is a bad sign because as I said, they have to be like 1, they have to be an equal. Or maybe drop a little bit, like 1% is okay, like 0.9. But if you drop less than 0.9, that means this occlusion, this artery is important and we're not tolerate an occlusion, you know. So this is wrong. This is a bad sign. So if the SPECT activity drop more than 0.9, that means this side will be affected if you ligate the artery. Okay.
Okay.
Okay. The next one.
So C, absence of xenon enhanced SPECT changes despite hemiparesis with hypotensive challenge during the balloon occlusion.
What they tell you here, what if the test came back negative, is all the equal, but he had hemiparesis? No, because it was bad. It doesn't matter about the test. You have a symptom, that's it, right? So you don't care about the test. So this is wrong. Okay, let's see next one.
D, lack of anterior cerebral cross-filling on injection of the contralateral carotid system.
Artery. Yeah, some people they do that where you're occluding one side, they go and they inject a contrast in the other side. If you see cross through the to the contralateral carotid sign, this is a good or bad sign?
This is a good sign that you mean you get a flow from the other side.
Correct. So if you don't see this sign, if you don't see the cross filling, this is a bad sign.
Yeah, lack of yes, sure.
Lack of the anterior cerebral cross filling on the injection of the contralateral limb. That means you inject and you don't see cross. So it's a bad sign. That means so this is not good. It's not favorable, right?
Okay. Yes.
It has to be the last one.
So the lack of neurological changes or xenon enhanced SPECT perfusion during 30 minutes of ipsilateral balloon occlusion.
Yeah.
So this is not correct.
Yeah. So if neurological change or was test.
Yeah. So 30 minutes.
Right?
Yeah.
30 minutes, and they put non-neurological changes after 30 minutes, or exon, or one of them. You don't have to do both, or exon enhancement SPECT perfusion test was negative.
Yes.
It is nice, you know. We use it sometimes, like in this case, you may see it in your real life, you know, because you get patient from with the tumors, you know. So really, you need to prepare yourself, and I think balloon occlusion test is very important, you know. I mean, luckily, all the patients I saw them, they were awake, so we have to do just occlusion and watch them for like 30 minutes, you know. But if it's an awake, I don't know. We have to look if they have SPECT activity here. Maybe we have to talk to radiology.
Dr. Samer, can I ask something?
Yes, please.
Did they mean that this is non-complete circle of wells, or there's another thing?
Yes, I mean, yes. But you cannot depend only on circle of wells. I mean, you cannot like I cannot, instead of doing like this, your question should be like, instead of doing balloon occlusion test, if I look intracranial and find circle of wells is intact, can I depend on this one as an assurance that if you occlude internal carotid artery, will be enough. So what do you think? Will be enough or no? You see what my question? My question, instead of doing carotid occlusion balloon, a patient do a cardiac, doing an angiocath, and and put
I
a
see.
balloon, invasive procedure.
Yeah.
Let's do intracranial CT and look at circle of Willis, and see
Yeah.
if we decide. I don't know the answer, but I don't think so, because things is not simple like that. Because like on any artery, a lot of collateral things. Circle of Willis is just one of them, but it's not the only. As we said before, you have an external to internal, sometimes circulations.
Mhm.
So I think just to look at the circle of Willis, I don't think I can give you 100%. This one can give you 100% assurance, especially as you're going for 30 minutes. But just to look at circle of Willis, I don't
not
think this
enough.
can give you enough assurance. I don't think so. I'm not sure 100%, but I don't think so. Maybe
Mhm.
somebody can look at that and let us know next time, All right.
Okay. Okay.
All right. Let's go to the 28th. We going now. Who's next? Amjad, right?
Yeah, I'm the next.
Yeah.
So,
I
at
think today the
55,
question is better than before. The last time the question all about trials and all things. Today is more interesting, more practical questions today, which is
yeah,
I think
yeah.
good. Yeah. All right.
So 55 years old, non-smoking man with no significant medical history presents after suffering from several episodes of right arm weakness, occurring with the turning his neck toward the left to look over his shoulder. Carotid duplex show no atherosclerotic change, normal velocity in the natural position, and elevated velocity and kink in the proximal internal carotid artery just beyond the carotid bulb. CT confirm a kink in a redundant carotid artery, the appropriate treatment for this patient.
Okay. Before we go that, so let's talk about kink. You see, today is all nice subject today. This is nice, really. And they mentioned the kink, if you remember, in the guidelines.
Yeah.
The kink of the internal carotid artery. It is not uncommon. We commonly see the kink. Most of the time, we don't pay attention to it, unless if patient two things. First, you have a symptoms, and second thing, you have something to confirm that it's coming from there. Like what they did here, they changed the head, and you see the elevation of velocity. But if you see symptoms and kink alone, you cannot tell 100%, because symptoms can come from anything else. Maybe from intracranial, maybe his emboli from the AFib, maybe has a plaque in the arch, right? So not only TIA with the kink can tell you the TIA coming from there. So what the guidelines, they said, you have to rule out everything. And if you roll out everything as a source of emboli and you don't find anything to claim except the kink, then you go and fix it. But in this scenario, they make it easier. They told you, no, we have an evidence that this symptom came from there, because when he turned his head, the velocity went up. So that means the kink is being affected with the neck movement. Even his symptom also, it's come with the neck movement. So all the scenario going with symptomatic kink, okay?
Yes.
So because asymptomatic kink, we leave it alone. We don't care about it. But symptomatic kink, we have to fix it. You know how we fix the kink?
Like the revision, endarterectomy will use the other revision technique. Revision.
You can do that. Revision technique, you can cut it. I mean, it's long, right? So you have to cut part of it.
Yeah, to shorten
and
it.
anastomosis. And you have to shorten it,
Yeah.
This is the way we fix it. You endarterectomy, sometimes we see kink with internal carotid stenosis. Then yes, then we do patch and we cut it, same times.
Yeah.
It's a special way technique. I'll show it to you later on. It's simple, it's not complicated. So the whole idea from kink is that you need to cut it and re-implant it, This is the easiest way, like an eversion technique, as you said. What about stent? Can we fix kink with a stent?
Can be, but would not be my first option. Patient's
Yes.
age is young.
55 and young. And the second thing is that what's the name? The stent will never fix a normal kink. Will fix a kink if you have it like with atherosclerotic disease, with a graft. But if the artery is soft and you put a stent, it's going, because artery is still same length. You just straight this area. So when you straight this area, what happened? The other area will go up. The kink will go up, right?
Yeah.
It's different from atherosclerotic. Atherosclerotic disease is different. It's a kink from atherosclerotic disease or from the graft is very stiff. So you put a stent, you just open it, you fix it. But when you have a normal artery kink, because the length is the same, and you put a stent, you just straight up this part. So when you straight this up, part of the kink, then this kink will be transferred up. So already you're not fixing anything.
Yes.
You just push it up. So stent will never really will fix the kink in the internal. We fix it in somewhere else, but not internal. So stent is not an option in this situation. Okay. So let's go now with these options. So he's asymptomatic and he has a kink and he's already on aspirin. So they said to continue aspirin, follow-up is needed. Is this a good option?
Symptomatic will not treat his symptoms.
Symptomatic, yeah.
He need to.
And he already on an aspirin, right? Let me see.
Yes.
I think he's already, but anyway, I mean, he's symptomatic and kink. It is anatomical problems, you know. If you put an aspirin, it will not, you know, help. So if symptomatic, it has to be fixed. It has to do a surgery. I don't think antiplatelets alone will enough, you know. Even if you follow up, how it's going to help? The kink will not go away, you know. So I don't think that will help. Next one.
Be additional of clopidogrel to aspirin therapy with a routine follow-up. Still, this medical therapy will not help. You need intervention. Diagnostic angiogram, placement of stent across the carotid kink. We said before, we don't prefer stent as treating
because it's going to push the kink up, as I said, because it's going to push the kink. It's not going to treat it, as I said. I don't know if you saw it. Sometimes we have, you know, when we see that in the external, same as external, you see, a lot of time we put like when you do an EVAR, it's very stiff, like sheath. You see a big kink in the internal, in the external carotid artery. So sheath like a stent, but the moment we remove the sheath, everything go back normal because it become very flexible. So when you have a kink, don't put something stiff. It just make it worse. Just push it up. Okay, next one.
Resection and reimplantation of internal carotid into the common carotid artery bifurcation. Sounds correct.
Yeah, it's a virgin technique. Yeah.
Common carotid to internal carotid artery bypass using interposition great saphenous vein. I don't think it will treat kink.
Yeah, I mean, it doesn't make sense really. It's too much to do carotid to internal carotid. We can fix it, resection and reimplant it. Sometimes this question even could happen, but doesn't make sense, you know. So the D, I think, would be the best answer. You just go and take it, cut the extra piece, and do reimplant it. You know, it's the best way. You know. All right.
Yes.
All right. 29, getting close. Hamad.
Bismillah. 61-year-old man presents with left upper extremity weakness. MRI of the brain confirmed a small right hemispheric ischemic stroke. Carotid duplex demonstrate approximately 65 stenosis of the proximal right internal carotid artery. A CT angiogram of the head and neck confirmed this finding, but also identified focal 65% stenosis in the cavernous segment of the internal carotid artery. So in this setting of a tandem intracranial carotid artery region, the most appropriate revascularization of
Okay. So we have, this is a good question. Today is all questions are good really. Tandem lesion, because you also may see it in your clinical life, you know. You see internal carotid 65, and then you go intracranial, you see other 65 or 70 or 80 or 90, you know. How to treat that? When I was a fellow, I knew how to treat that, and we used to read it, and until now, still the same. We didn't change. Do you know do we need to treat them both? We need to treat because he's symptomatic, right? He's symptomatic. He has 65% stenosis, correct?
Yes, doctor.
Okay, so we talk about
And there is
65%.
intracranial, yes, and he has a stroke also.
Okay, so he's symptomatic. So we're talking about 65% internal carotid and intracranial and extracranial carotid stenosis, correct?
Yes.
So nobody argues that he needs to be fixed for the internal at least, correct?
Sure.
This is out of question because he's symptomatic, 65% need to be fixed. This is a guideline of the, you know, of the carotid. So the really the tricky is we're going to do the second part. Are you going to fix it, leave it alone, or do them together, or put stent for both together, or just do surgery here and leave it alone, you know? Well, I tell you what, when I was in fellow, they used to say, just fix the internal, don't worry about the intracranial, you know? Then things get better now. They're doing a lot of ballooning and stenting inside the brain, you know? So I got a patient who had very similar, I think 2 years ago, was about 70, 80% symptomatic, and he has intracranial was 80% really, or 85%. So I sent to intervention to do the intracranial, then I do my surgery. And then he's called me back, the intervention said, no, there's a study, new study showed there's no advantage at all for intracranial ballooning or stenting. It doesn't matter how, even 90%. The study showed that is increased risk and stroke and death and all those things. So he asked me to treat him medically and just go do that. It didn't make sense to me because 90% was very tight, but then I went there and read about it. And really, yeah, they have a trial where they look at the intracranial stenosis, and they found that medical treatment, best medical treatment is better than any intervention for intracranial arteries for stenosis. The reason why, if you have intracranial stenosis in the neurointervention, they're going to say just medical treatment. But you have to be aggressive. Usually they give statin, they give aspirin, and they give Xarelto, factor 10 inhibitor. They give them 3 of them. They're very aggressive. So this is a new now guidelines. Intracranial medical treatment. Nobody do any intervention, even if it's 80, 90%. Carotid, we follow up the same protocol we do. It will not affect by the current with the intracranial lesions, okay? Not negative, not positive. We don't worry about it. We don't look at it. We just look at intracranial, extracranial stenosis, and we go with a guideline. Is this clear?
Yes, clear, doctor.
Okay, let's go through the question now. See what they said here.
So a revascularization is not indicated in the setting of the tendon carotid artery stenosis. Carotid endarterectomy with extracranial.
Is wrong or correct?
The first one, yes, it's not indicated.
So no. He talked about, no, let's say he said, the most appropriate revascularization. He taken revascularization of both, and he's talking about both. Is not indicated in setting of tandem. So you're going to leave it alone, this patient?
No. He needs carotid endarterectomy and
yeah. So this is wrong. Revascularization is not indicated in the setting of tandem. This is wrong. No. We still do revascularization of the internal is stenotic enough, more than 50%.
Yes.
Okay. So this is wrong.
So
next one.
Carotid endarterectomy of the extracranial internal carotid artery stenosis. Yes, this is the only thing I will do. See external internal carotid artery bypass. We
this is by default is wrong.
No. Carotid angioplasty and stent placements in both of extracranial and cavernous ICA stenosis. No. And carotid angioplasty and stent placement in the cavernous ICA stenosis around. Also no.
Yeah. So no. And Amjad, you can talk to, you are doing now radiology, you can check with the neurointervention if any change, but this is the guideline. I remember any intracranial, they don't do any intervention, but you can check with them and update us if any change or any new trials. But until now, as far as I know, intracranial carotid stenosis is just medical treatment, okay? Otherwise, if it's not correct, then the D will be the right answer to do both, stenting both. If it's indication for stent, yes, I'll do stent for both because it's easier, you know. But again, because the new study showed there's no advantage of stenting, then medical treatment. Same like with the renal, we used to do a lot of renal stent, and nowadays we really do a renal stent because the study showed there's no advantage of stenting of the renals. All right, let's come to the last question. What time is now? Oh, 44. Sam, let's finish this question. Hopefully it'll be an easy one.
Compared to transfemoral carotid artery stenting and carotid endarterectomy for the treatment of asymptomatic carotid stenosis, transcarotid artery revascularization is associated with
Okay,
TCAR.
before you go, TCAR. You
Yeah,
know how they do TCAR?
yeah, I attended once with
Okay.
you.
So what happened? You just make small incision at the base of the neck. You go directly to the common. You put your sheet and you do stent.
Yeah,
The advantage of TCAR from the CAS, the stenting, is that you don't have to go through the arch. Because most people, because if you have a disease arch, most people they embolize even before you put a filter because you have to go through the arch to the common, to the internal before you put an what's the name,
filter.
the filter.
Yes.
So if you have a disease arch, you can get a TIAs and stroke even before you get to put a filter. But if you use a TCAR, carotid, then you don't have to go directly to that. So you have less chance of stroke. So it showed less chance of stroke than CAS, you know?
Yeah.
And become very similar to the carotid really, stroke rate, you know, because very similar, because you have a control, you know?
Yeah.
The only disadvantage, you have to make small incisions in the neck. This is the only disadvantage. You have to dissect all this. You have to be a pit surgeon, you know. You have to make a small cut, go all the way to the internal, the common, dissected. So it may be a bit more difficult for the interventions, but for surgeon, piece of cake, you know. All right, so this is the advantage. And it become very, very popular now, procedures these days now. Okay, let's go through what they said about it. So
And do we have to put a filter with the TCAR also?
Yes. The same, exactly the same. The only advantage is that you don't have to go through the arch, but the same. Some people, they do it with a reverse flow. This is what the TCAR really, most people, they do it when they do TCAR, they do a reverse flow. Reverse flow, they put a balloon in the external, one is the internal, in the common and the external. So you have a reverse flow. So all the plaque will go down, will not go up. They take the blood, they put it through the filter, and then goes back to the femoral vein. You know, but you can modify it and use a filter.
Okay.
Okay.
So lower peri-procedural stroke risk than CAS. Yeah, according to the discussion, yes.
Yes. Correct.
Higher peri-procedural stroke risk than carotid endarterectomy.
No.
Mm-hmm.
Because you see, CAS was higher. See, when they compare about CAS and surgery, the CAS had higher chance of stroke than surgery. You know?
Yeah.
If you just look at the stroke. So when the TCAR come, it was able to drop the stroke rate in the stenting down to the level of the carotid endarterectomy. Reason why it become more popular. So now TCAR and carotidectomy always the same level of stroke, you know?
Yeah.
So this is the advantage of TCAR. That's why people like to do it because you decrease chance of stroke.
Yeah.
Okay.
Higher cranial nerve injury rate than carotid endarterectomy? No. The surgical will,
it's more.
small.
Even you can get a nerve, you can get like that because you have a biggest nerve, you can damage it, you know, because you have to go to the common carotid arteries, a dissection.
Yeah.
But still, it's not like the surgery. Surgery, of course, more dissection, more nerve damage. You have hypoglossal nerve, so it's not higher for sure. No. Okay.
Okay. Equivalent anatomic constraints to CAS? No.
No,
Because we don't go to arch. Yeah.
Correct. The CAS, you can do it for arch type 1 and type 2. You can do it for type 3. Whereas the TCAR, you can do it for any type of arch because you don't care, you know?
Yes.
All right.
Higher long-term stroke death rates than carotid endarterectomy. No.
The same, really. There was no difference. They found this between surgery and death and stroke. So the right answer would be A.
The answer is A. Yeah.
As I'm saying, the only reason why they didn't really came with this technique is to decrease chance of stroke, which they did, All right, I think that's all for today. It's enough. I'll get you longer than you expected, guys. 30 is good in a question. Take a lot of time raise questions, almost like 45 minutes. All right. Any questions? Not 45, right? An hour and 15 minutes.
Yeah.
Any questions before we leave? Anybody, any guys attending this meeting? Any questions? No. All right, guys. Hopefully we'll see you next week.
Thank you
Take
so
care.
much.
Thank you,
Okay, bye-bye.
Doctor. Allah يعطيك
Thank you.
العافية.
Oh, this is one.